Welcome everyone to today's webinar. I am Ayla Ellison, Managing Editor of Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Gina M. Bruno serves as NavaHealth's Vice President for Clinical Strategy, where she is responsible for care redesign, service model innovation, and business strategy to drive value for patients and partners. She is considered a thought leader in value-based care and in managing change in clinical settings. Prior to joining NavaHealth in 2015, Gina worked at Booz Allen Hamilton in Washington, D.C., where she led strategy and transformation engagements as a certified change management advanced practitioner. Gina has a BA from Harvard and an MBA from Vanderbilt University, where she completed an internship at Massachusetts General Hospital in independent studies in senior living, palliative care, and hospice, including consultative work hospice in Botswana. Tom Deviney serves as NavaHealth's Director of Strategy and Business Development, where he is responsible for growth strategy and establishing new partnerships with providers in value-based care. He is particularly focused on serving provider organizations that are developing post-acute care strategies to succeed in CMS-led innovation initiatives such as bundled payments and ACOs. Prior to joining NavaHealth in 2015, Tom worked at Avondale Partners in Nashville, Tennessee, where he worked on healthcare mergers, acquisitions, and capital raises. Tom has a BA from Davidson College and an MS from Wake Forest University. Gina, I'll now turn the floor over to you.
Thank you so much, and thank you everyone for joining us today. Tom and I spend many lunch hours talking about BPCI Advanced, data and insights, and we're thrilled to have you join our conversation today. For those of you who may not be as familiar with NavaHealth, I wanted to begin with just a brief overview of our organization. NavaHealth serves health plans, health systems, and post-acute providers by deploying scalable technologies, advisory solutions, and clinical services. We're particularly active in helping to support our partners in the shift to value-based care. And today we're coming to you with our experience as one of the largest conveners in BPCI Model 2 today. I'll spare you the details on the slide, but want to reference that we manage over 40,000 annual episodes of care across 10 states in which we have BPCI operations. It's this expertise and experience that we're bringing forward today in our conversation around BPCI Advanced. We have three goals for today's webinar. The first is that we hope to share some insights and education on the importance of optimal episode selection for BPCI Advanced, using analytics primarily, but other supplemental insights and qualitative information to make those decisions. The second is we hope to introduce and explore some of the analytics and reporting capabilities that providers will need to be successful in managing BPCI Advanced operations on an ongoing basis. And finally, we hope to discuss how and why data can be critical in developing care redesign and performance improvement strategies to help deliver results and continue to enhance the patient experience and impact on the bottom line going forward. Tom and I will collaborate on the discussion today, and I'll turn it over to Tom to begin our discussion. Stuck here on my slide for a moment, it's live TV. To begin our discussion with part one of our two-part webinar, exploring BPCI Advanced episode selection. Tom?
Great, thank you, Gina. So we thought it would be helpful to start with a quick overview of what to expect from CMS over the next couple of months. So at some point within the next 8 days, CMS has indicated that they will be providing all of the historical claims data and target prices to enable BPCI Advanced participants to evaluate episode selection. This data will be made available for the BPCI Advanced data portal, and CMS will be providing instructions for how to access that data portal in the coming days. This data will be made available to the individuals that were listed on the DRA that was submitted to CMS as part of your application submission back in March. In June, CMS will be providing model participation agreements so that participants can understand all the commitments they will be making to CMS with regards to participation in BPCI Advanced. Secondly, participants will receive information about the calculation of the composite quality score that will be a factor in the NPRA calculations in BPCI Advanced. While CMS has provided a list of the factors that will be considered for this quality score, we don't yet know the methodology. And so I think this will be something that participants will really want to dig into upon receipt of that methodology. And then in July, CMS will be providing templates for 4 required deliverables. The first is the participant profile, and this is really what must be submitted to CMS by August 1st that has all the episode selection decisions. And then the next 3 are the care redesign plan, the financial arrangement list, and the physician group practice list that will be needed to be submitted in September to CMS. A couple of key considerations that relate to episode selection that we think are different in BPCI Advanced than BPCI Classic. And specifically, these 3 factors we view as favorable changes in the BPCI Advanced methodology when it comes to choosing the right episodes for participation. The first pertains to baselines and targets. And CMS is risk adjusting the baselines and target prices in BPCI Advanced. And in our view, again, this is a big improvement in the new target price methodology. As some of you may know, today in BPCI Advanced, it is possible for providers to either benefit or be penalized if the acuity of the patient population they see in a given performance period is different than the case mix and acuity of the patient population in the baseline period. And so by CMS introducing risk adjustment, this eliminates that sort of unfair penalizing or unfair benefit to providers in the BPCI Advanced program. The second area is trend. For current BPCI participants, they know that a national trend factor is a component of NPRA calculations each reconciliation period. And today, this trend factor is actually provided retrospectively. So at the end of a performance period, CMS adjusts the target price up or down depending on national trend. Going forward in BPCI Advanced, this trend will actually be incorporated prospectively into the preliminary target price that is provided for each episode group prior to each performance period. And so when it comes to selecting episodes, this isn't necessarily something that will be as big of a factor this time around when forecasting what episodes are going to make sense for your organization. Lastly is wage index. Again, wage index is a distinct factor in the NPRA calculations in BPCI today. However, going forward, this is no longer a standalone factor. And frankly, in today's methodology, there are some winners and losers based on wage index adjustments each performance period. And CMS has adjusted the target price methodology in BPCI Advanced to sort of eliminate those types of winners and losers in this program. So I think forecasting wage index and the impact on your organization is really not something that needs to be considered very heavily in BPCI Advanced episode selection. All right, so what does the episode selection process look like from here? CMS is going to provide 3 years worth of claims data at some point within the next 8 days. And this is really the historical data set that will be the baseline period upon which your target prices have been generated. From there, participants will need to transform that data to understand what this data looks like at the episode of care level. So CMS will be furnishing claim level data to participants, and participants will then need to be able to apply the BPCI Advanced business logic to transform this claim level data into episode of care level data and then make informed decisions based on what is seen in those episodes. Participants will then make their selections during the course of June and July, which will result in the submission of a participant profile to CMS that has all the episode group selections for each episode initiator by August 1st. All right, so why is episode selection important in BPCI Advanced? I think first and foremost is that downside risk does begin in this program beginning on October 1st. And this is something that's a little bit different than the BPCI Classic program. For those who participated in BPCI Classic, you may recall that there was a phase-in period where downside risk was not introduced to certain providers. And so this sort of allowed providers to get their feet wet, understand what was going to be needed to drive results, and then make adjustments accordingly. That is not going to be the case in BPCI Advanced. And so I do think it's particularly important for providers to make the right decisions coming out of the gates in this program. The second pertains to MACRA. Given that BPCI Advanced does qualify as an advanced alternative payment model under MACRA, the episode groups that providers select will have implications for how eligible clinicians can or cannot meet their MACRA criteria. And so I think picking the right episode groups that engage the right specialists that want to meet their MACRA requirements will be an important factor when choosing the right episodes for your organization. And then lastly is that episodes need to be selected that match how your organization is investing in care redesign. So, the implication here is that, based on the review of all of the historical data, there will be savings levers that become apparent for how total cost of care can be reduced for each episode group. And so if the savings is going to be generated from reduction in readmissions, for example, you need to be confident that your organization has the capability to influence readmissions. On the other hand, if the majority of the opportunity is going to sit in a reduction in skilled nursing facility utilization, you'll want to make sure that your organization is investing in the capabilities to influence those skilled nursing facility outcomes.
Thanks, Tom. Before we dive deeper into some considerations around the quantitative and qualitative factors for episode selection, I'd like to go to our first quick poll and ask you, how prepared is your organization to select your episodes for BPCI Advanced? We'll take a few moments here to allow attendees to vote in this poll. All right, we'll give it just a few more seconds here. And then let's go ahead and close the poll. So I'm sure this won't come as too much a surprise to folks on the line that the majority of you are making progress. And I think sometimes we all feel that way as we get ready to implement BPCI Advanced. For those of you that answered honestly that you're feeling a little bit behind the 8 ball, I hope that the conversation that Tom and I will have in the next few minutes may give you a bit more confidence that you're ready to take this on. What we'll talk about now going forward are some considerations for episode selection that we think really drive your optimal scope of participation. It's Navajo's opinion that the best approach here is one that is data-driven and objective, that leverages all the information that CMS will provide. However, looking just at the data itself is insufficient. What we need to also do is ensure that there is a qualitative lens that takes into consideration those factors that are germane to your organization to be able to put those two pieces together. So with that, I'll have Tom kick us off on the quantitative factors. Thanks,
Gina. So what does your organization need to look at in the data that will be received from CMS in the coming days? We've really broken this out into 2 categories. The first is selection of the right episode initiators. So for a health system or a large physician group practice that has multiple TINs or hospitals that can participate, how do you hone in on the right ones that are going to present opportunity in BPCI Advanced? And then secondly, within each of those episode initiators, what are the right episode groups for that particular episode initiator? I think it's our view that across both of these, the number one sort of quantitative factor that should be considered is the historical post-acute utilization patterns that exist either for that hospital or physician group practice and in that specific episode group. So this is really the number one thing that participants will want to wrap their heads around when evaluating if an episode group presents opportunity from a data-driven perspective. Back to the episode initiators, I think there's a couple other things that we would suggest considering based on your review of the data. First is going to be the size of your peer group. So for those who dialed into CMS's webinar last week on the target price methodology, you know that a factor in your target price and how that will change over time is a comparison to your peer group. So I think understanding the size of this peer group and whether it's just a handful of providers or hundreds of providers will be critical in determining whether it makes sense for that episode initiator. Second two are really volume, eligible volume for participation in this program, as well as the operational efficiency for executing on the opportunity at a given facility. And these are definitely related. I think, in our view, there is certainly an investment, perhaps monetarily, and definitely in time and energy to drive results in this program. And you'll want to make sure that there's sufficient volume going through a given facility or your physician group practice to justify the time and energy required to succeed. On the episode group selection, I think we would propose that the primary thing that you'll want to consider is the perceived ability to drive post-acute utilization savings in these episodes of care. So obviously you'll want to look at the historical utilization patterns, but just because there's high utilization of post-acute in a given episode group may not be that it's manageable utilization. And so I think you'll want to do a lot of benchmarking compared to national averages, perhaps best practices, to understand whether there's an opportunity within a given clinical condition to eliminate some of that unnecessary utilization. Next would be your target price. While we don't expect a ton of quote unquote arbitrage coming out of the gates with target prices, I think we do think it's important to understand how your historical average costs compare to your target price that you'll receive from CMS. And then again, you'll want to make sure that there's sufficient volume in any given episode group so you're not subjecting yourself to unmanageable risk for outlier cases.
Great, thanks, Tom. As we mentioned, in addition to the quantitative data that will come through claims or in some of the target price information, there are also qualitative factors that we should be considering, or we recommend considering, as you think about episode selection. Again, looking at this for both hospitals and at the episode group level. As we think about site selection, the post-acute community is one of the first things that we think about here at NaviHealth. First, around the quality or performance of that post-acute community, and then second, around geographic distance. And so the first piece is really making sure that those post-acute providers that are in your community can deliver the outcomes that your patients will need to be successful throughout a 90-day episode of care. However, coupling that with a geographic consideration ensures that those high-performing providers are in fact located in areas where your patients can access them. Additionally, as Tom mentioned earlier, macro considerations come in play here for employed or affiliated physicians, making sure that we're thinking about those sites and affording the opportunities for them to participate using BPCI Advanced as an advanced APM under MACRA. The fourth bullet here, while last on the list, may be one of the most important, and that is around the infrastructure or organizational readiness for value-based care. Where organizations have been successful in our experience has been in investing in the teams and coordinating mechanisms and strategic communications to really bring on board all of the key stakeholders that will have a role not just in episode selection, but in ongoing performance of the BPCI Advanced program. As we think further about episode group selection, there are a couple of additional factors. The first is around physician engagement and the alignment of incentives. As we think about where your hospitalists, specialists, and others may be engaging, it's going to be critical here to make sure that there's a match between those clinical conditions and the role that your physicians and physician leaders will play. While gain sharing and NIPR sharing are beyond the scope of today's discussion, those are going to be important considerations for you as well with respect to physician alignment. Second, DRG identification and coding. For those that have worked in prior models, the current model of BPCI, know how challenging it can be to work on a working DRG. So as you think about your team and their ability to code accurately and timely, that will be a lever that will be important in thinking about your episodes. And then finally, alignment with clinical programs or protocols that your organization may have established for other population health or value-based care initiatives. This is critically important here as the quantitative data will take us through 2016. You may have made investments and developed enhancements in your clinical programs over the past 18 months that give you additional lift into what is possible in working with your opportunities for savings in BPCI Advanced.
Great. And then I think the last thing that we would consider really taking a hard look at are some exogenous factors that that are introduced based on the precedence rules that were outlined for BPCI Advanced. So I think we would really break this into two different categories. The first is Medicare ACO overlap. So some of you may know BPCI Advanced has precedence over MSSP Track 1, Track 1 Plus, and Track 2 ACOs. However, MSSP Track 3 and Next Generation ACOs have precedence over BPCI Advanced. So as you are thinking about whether it makes sense to enter into BPCI Advanced, I think it's critically important to understand the ACO landscape and the implications of either BPCI Advanced quote-unquote trumping volume or savings that could be attributed to your ACO, or alternatively participating in BPCI Advanced and having a lot of volume that is carved off the top due to Next Gen or MSSP Track 3 attribution. The second one here really pertains mostly to hospitals, and this relates to PGP precedence. So again, the precedence rules that CMS outlined for this program are such that an attending physician that is initiating an episode of care has the first precedence. Second is an operating physician, and then third is the hospital where that procedure is taking place, where the episode of care is beginning. So if you're a hospital evaluating how big you want to go in BPCI Advanced, understanding the physician group practices that are going to be participating and initiating episodes of care will be a critical determinant of perhaps what episode groups you select, or at least understanding the potential volume and the opportunity that exists for your organization in BPCI Advanced. Great, just want to spend a little bit more time talking about the peer group comparison. As I mentioned earlier, one factor that you're going to want to consider when choosing what hospitals or physician group practice tends present opportunity in BPCI Advanced is the size of your peer group, because this does have an impact on your target price and how your target price will change over time. I think the key implications here are that if you're part of a small peer group, any fluctuations in the trend for that given peer group will be magnified or more pronounced if one provider in that peer group experiences increased efficiency or decreased efficiency. Alternatively, if you're part of a large peer group, I think the impact of any one provider on your target price will be diminished because it's going to be spread over such a large peer group. So, NaviHealth, we've taken the exercise here. We have mapped all of the hospitals in the country to the peer groups per the CMS methodology. And for those, many of you on the phone may know the factors that go into the peer group classifications, and there's 5 factors. First is bed size. Second is an academic medical center or non-academic. Third is an urban versus rural distinction. Fourth is a safety net hospital or non-safety net. And then fifth is your census division. So basically when you map hospitals using this criteria to peer groups, there are over 400 possible peer groups across the country. And the average number of hospitals per peer group are 30 hospitals. However, there's pretty significant variation in the size of these peer groups. So based on our mapping, we've identified one peer group that just has a single hospital in it. And then we've identified others that have over 250 hospitals in the peer group. So I think understanding, which of your hospitals are mapped to what peer group will be definitely something that you're going to want to consider when making decisions about your scope of participation.
Excellent. And for those who may be on the line looking closely at this map, I'm sure we can't see you through your webcam, but if you're anything like I was when I first saw this, began to look at some of this color coding, and will reiterate Tom's point that with 400 possible peer groups, what you're seeing as potentially similar colors are actually on quite a broad spectrum that is not visible to the naked human eye, as we've come to learn.
Thanks, Gina. So, how does this get manifested in how you all would make decisions around scope of participation? I think we've tried to, sort of distill this into a very simple metric to look at. Over the baseline period, I think, what we would suggest doing is looking at your organization's trend for a particular episode group and compare that to the peer group's trend for that same episode group over the same time period. And I think this would sort of be a flag to identify whether a comparison to peer group may end up being favorable or unfavorable for your organization. So, the high level is that if, your organization has achieved increased efficiencies year over year in the baseline period, where you see total cost of care coming down, and your peer group has seen total cost of care go up during the baseline period, this is indicative of perhaps a favorable episode group for that peer group comparison. And then the flip side is also true. If your costs have been going up year over year and the peer group's costs are going down, this might be a risk or something that we would flag as you think about choosing the right episode groups.
So before we move into part 2 of our webinar, we'd like to open it up for our second quick poll and understand from you, what is the primary factor driving your episode selection decisions? We'll give the poll a few minutes to remain open here as folks answer. Give it a few more seconds. Then we can go ahead and take a look at the results and share them with you on the line as well. So interesting here, a very diverse group that's looking at service line engagement, favorable target prices, and utilization patterns. Interestingly enough, that for many folks on the line, the macro advanced APM qualification while a factor may not be the primary one. And I'm sure that many of you are likely fighting the urge to select multiple or maybe all that apply. They're very interesting to see here the ways in which these factors are changing the way that we think about episode selection. So moving forward into the second part of our webinar today, we're going to focus a little bit on ongoing data and performance analytics for managing BPCI Advanced. We're going to talk about that in 4 areas. When we think about utilizing data on an operational basis to manage and monitor performance, we think first about financial performance. So how am I, or how is my organization performing with respect to the cost savings that I'm able to achieve? Second, our key performance indicators. So what are those levers or factors that are driving my performance up or down? Third, provider and episode group dashboards. So how can I take a look at those providers within my organization and within my community, and how they are impacting episode groups and results across the continuum? And then finally, we'll spend a couple of moments talking about performance improvement and care redesign, and how you might be able to take those operational insights and be able to use them to drive improvements over the course of the program. I'll turn it to Tom to get us kicked off.
Perfect. So the first area, as Gina mentioned, is going to be financial performance tracking in this program. And I've been out talking with many providers over the last several months about BPCI Advanced and the importance of data. And, I think many of the providers that I've talked to that participated in BPCI Classic had no idea what their financial performance was until the first check showed up from CMS. So I think this is this was pretty pervasive throughout many of my conversations with provider organizations. So I think, in order to properly manage this program, it is really critical to have the ability to forecast your financial performance, both so you understand how the program is going and can make appropriate decisions, as well as for internal stakeholder engagement, communicating with your CFO, being able to book revenue. These are critical things that that participants should be mindful of and seeking in BPCI Advanced, is the ability to manage to a financial performance forecast. So providers, in order to do this, it's somewhat difficult and complex. CMS provides monthly claims data to participants in BPCI Advanced. However, they're not providing, calculation of savings or preliminary estimates of your savings. And so what participants must be able to do are to take that claim level data and attribute claims to individual cases, estimate completion factors based on run out and timing, and then ultimately forecast NPRA results. And I think at NaviHealth, this is really something that we have invested a lot in over the last several months to provide visibility to our partners and internally on how our program performance is going. So the next is key performance indicator tracking. So it's important to understand the dollars and cents and have visibility into cash flows in the program. But I think perhaps more important is understanding what is driving the performance. And so what we do is we have a standard set of key performance indicators that we like to review on a monthly basis for all of our partners and all of our episode initiators to understand what is driving program performance. Most of the key performance indicators that we like to look at do come from the post-acute part of these episodes of care. So it's looking at discharge rates to post-acute facilities, both at the level of care as well as which type of providers patients are going to. And it's also looking at length of stay in the skilled nursing facilities, as well as 90-day readmission rates. So I think having this standard set of key performance indicators so that you can have the right visibility and really be able to understand what is driving your financial forecast will be critical to success. The next category is provider dashboards, So with the key performance indicator tracking, we understand at a high level what's driving program performance. I think the next question is, what are you going to do about it, If you are seeing that certain key performance indicators are not what you expected or not trending the right direction, these provider level dashboards can enable you to craft the right performance improvement strategy to think about how you would manage some of those key performance indicators better. And so we do this really in two primary ways. The first is looking at post-acute provider dashboards. So based on where patients are admitting for each episode group, we look at a side-by-side performance of how the different post-acute partners are delivering outcomes to these patients. And we like to look at both efficiency metrics as well as quality metrics for these providers so that we can continue to evaluate which providers we want to work with and how we can work with them to develop the right performance improvement strategies. And then second is physician level dashboards. I think this is an area that we've seen be particularly effective in BPCI Classic, is the ability to really drill down and understand for a given clinical condition how or what variation might exist amongst the group of physicians that are seeing patients in these episodes of care. So by being able to pinpoint variation, identify high cost outliers, it enables having the right conversation with these physicians to talk about perhaps certain behaviors that you might want to manage or develop performance improvement strategies based on what is seen in the data.
Thanks, Tom. Before we dive into those performance improvement strategies, I'd like to tee up our third and final quick poll. Given what you've just heard from Tom and what you know to be true in your organization, we'd like to know, how does your organization plan to monitor performance in BPCI Advanced? And as with the others, we'll give this a few seconds for folks to respond. Okay, we'll give it just a few more seconds. Let's go ahead and share those results. Interesting, again, much like with our last question, some diversity across our respondents, but encouraged to see that over 40% of you are looking at doing this in-house, which means that you likely have made some investments in data analytics and data science to equip your organization to do that. For those of you, the 13% that are honest today about still figuring that out, hopefully the conversation that we have been having over the better part of this hour and the next few slides will give you a little bit more confidence to begin to tackle that. But really excited to see and encouraged to see all of this work preparing to use analytics to manage program performance. The last few slides of our webinar before we open it up for questions focus on performance improvement, that fourth line that we talked about, and using performance improvement and all of the data that is available, including the data that Tom had talked about, to drive strategies for care redesign. As most of you likely know, CMS has made it very clear in this program that the emphasis is on care redesign, on the patient experience, and on achieving high quality outcomes. That's really hard to do without data. You can see in the graphic here, there are a variety of ways that you can improve performance across the continuum, beginning pre-acute, for example, improving pre-op assessments and pre-op programs for your surgery patients, through the acute setting, the post-acute setting, and even into community. One key way, for example, to help avoid eventable readmissions for patients who return home is to really strengthen those relationships with community providers who can deliver resources. What you have here in these thought bubbles are just a few examples, but as you might be thinking and wondering, as I often do, how do you tackle these when the data coming from claims, and especially reconciled claims, has such a lag? It's also quite relevant, and Tom mentioned CQS, the composite quality score, earlier in this conversation, and the challenge of waiting for more clarity around that methodology. Looking at care redesign and performance improvement, even as we wait for that methodology, is key in thinking about how you can capitalize on your own high quality performance to take advantage of that composite quality score. However, as I mentioned, it's hard to think about operational measurement and performance improvement without real-time data. And so what I offer for you here on this slide is what we're calling real-time to reconciled. Of course, reconciled claims data is that source of truth that we look for at NaviHealth, and many of you likely will and do as well. But it's hard to wait for that perfect data set while we have opportunities to improve in real time. We do know that we have operational data. It may come from A37 files. It may come from your EMR. It may also come from care transitions or care management products and platforms that you might use. And this data isn't perfect, I'll be the first to admit, and it may be a little bit messy, and I certainly wouldn't want to make financial decisions on that close to real-time data, but you may find that it is sufficient to drive timely care redesign. What you see here on the right-hand side of this slide is just an illustrative example of something we call a developing readmission rate. Combining our reconciled claims data, our monthly claims data, and our near real-time data from 837 files and our care transitions platform, we're able to begin to project out what we expect something like the readmission rate to be. So as Tom talked about KPI reporting, we'll look to claims to give us that ground truth, but we can look to this operational data to give us that canary in the coal mine so that we can take action now on programs, initiatives, change management, partnerships, and so forth to begin to drive change in the moment, and then looking for the same data operationally. I tell people they may be bruised apples, but it's apples to apples, and then looking at the claims data towards the end as that time runs out to give us the true validation on the impacts of our strategic initiatives and pilot projects. So in closing, with data just a few days away, or any day now really, we wanted to offer a few thoughts on what Tom and I felt you could and should do right now. The first is to identify influencers and key decision makers that are going to be critical in your organization's decisions around episode and site selections. Based on your poll responses, many of you have likely already done this, but engaging them early and aligning around your objectives in an incredibly tight time frame is going to position you for success. Second, we recommend that you set expectations and seek to eliminate bias in the decision-making process. Eliminating bias completely is impossible. We are human beings, but aligning your team around the objectivity that's inherent in data analytics is going to be helpful. That may prevent tangential conversations about what we think might be true or wish would be true, and instead look at the data to help begin to expose that narrative. Third, while it may be early and October may still seem far away, it's not too early to finalize your BPCI Advanced team. That may include the colleagues within your organization that are responsible for data analytics, as well as care redesign, financial oversight, reporting, and so forth. Likewise, it may include your external partners. So some of you in the polls indicated that you are planning to work with a convener or planning to work with a vendor who can provide data and analytics support. Now's the time to really finalize and think about what you need out of those partnerships to be able to manage the program successfully in the long run. And then finally, we recommend establishing what we call an insight strategy. More than just simply processes for analyzing data, but really a full thought out strategy for how you will consume the data and the stories that that data tells you for ongoing performance management, care redesign, and performance improvement. These are 4 steps to get you on your way, but we're hopeful that with these 4 steps and the information that we've talked about, you're feeling a little bit more confident, a little bit more ready to tackle episode selection and BPCI Advanced. With that, we will open it up for questions and look to the Becker's team to help facilitate.
Well, thank you, Gina and Tom, for that fantastic presentation, and to NaviHealth for sponsoring today's webinar. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. We've already had several questions come in today, so we'll go ahead and get started on those. And the first question for our panelists today is, does NaviHealth offer analytics services only as a convener, or could a hospital or PGP access those services outside of the convener relationship?
It's a great question. NaviHealth does provide analytics services outside of a convener relationship. So we are, in the process of talking to many systems about partnering as a convener, and the analytics and reporting capabilities are an integral component of that offering. However, we can also make that available on a standalone basis for providers that are looking to participate on their own without a convener in BPCI Advanced.
Thank you, Tom. And go ahead and move on to the next question. And this question is, has CMS released instructions on how to access the data and create an account to gain access to the data portal yet?
That's also a great question, and for those who can't see me, I'm smiling on the other end of the line because CMS just emailed earlier today, maybe about an hour ago before this webinar, with some additional information about accessing the portal and instructions for registration. That email indicated that registration would open tomorrow. So do encourage folks who are on the line who have applied to connect with the points of contact that are on your DRA form. Those are likely the individuals who would have received that email and would receive information from CMS on instructions for registration.
Perfect. Thanks for providing that additional information, Gina. And the next question for our panelists today is, how big of a factor will the peer group adjusted trend factor be in the target prices?
Very good question. So, we obviously did spend some time today talking about how to incorporate the peer group adjusted trend factor into your episode selection decisions. However, it is our view, based on our interpretation of the CMS target price methodology, that this will actually not be that big of a factor in selecting episodes. Based on the conversations that I have had with many providers over the last several months, I think providers are sort of over-indexing to the importance of this trend factor. I think many folks are comparing this methodology to what existed in the CJR program, where you actually had weights, where a certain weight of your target price was based on your historical utilization, and there was another weight that was based on your region. And that methodology really created these direct comparisons to your peers that presented itself in distinct financial either tailwinds or headwinds. But that is really not the methodology that CMS has outlined in BPCI Advanced. And so it's our view that this will not be a huge factor in identifying episode groups that will make sense for BPCI Advanced.
Thank you, Tom, for clarifying that and providing more information there. We've had several more questions come in from our participants today, so I'll go ahead and move on to the next one. And this question is, can you please detail how the risk adjustment works? For example, how are hip fractures handled differently than non-hip fracture cases for DRG 470?
Yeah, sure. So, the risk adjustment methodology is definitely complex, and I'm not an actuary, so I can't speak, super fluently to this. But what we can say is that CMS will look at the DRGs that make up a particular episode group, right? So, if we know that sepsis includes DRGs 870, 871, and 872, and that the types of patients that get coded as each of those DRGs look and feel very different and have different costs of care, CMS will adjust for the mix of those DRGs that is experienced in the performance period and adjust the target price if that case mix is different than what we saw in the baseline period. So, in our view, this is a very fair way to account for changes in acuity that providers experience during the BPCI Advanced program.
Thank you, Tom. And moving on to the next question, this participant wants to know, can you share a tangible example of how NaviHealth has used real-time data to drive results in the current BPCI program?
Yeah, that's a great question. It is the bulk of my work some days. We've really used this in a lot of respects. We have worked on a variety of care redesign and pilot projects, all within the program constraints of BPCI Model 2. The example that I can give that may be helpful for folks is we were partnering with a hospital here in the southern part of the United States, and that hospital was experiencing a spike in readmissions, especially for some of their cardiac patients. We were able to first identify that with some early indicators from our monthly claims files and investigated that with data from our care coordination platform, what are our most real-time data, if you will. The pilot, in very brief context, was focused on increasing the adherence to and referral to home health services for appropriate patients, and working on a variety of processes within the hospital to do that. And we were able to use our real-time data, again, comparing those bruised apples to bruised apples, to look at readmission rates for CHF patients pre and post pilot to begin to get a look at whether we were in fact moving the needle. So think about percent change rather than absolute readmissions. And we're able to use the data that we had through clinician notes and records to look and measure where this pilot was happening in a process perspective, and then take that data to look at results. What we were able to see in that developing readmission rate sense was a double-digit relative decrease in readmissions for that patient population. And then we're able to look at that in our claims data over time to validate what we saw in the developing data.
Thank you, Gina, for providing that helpful example. And we still have several more questions we're trying to get through today, so I'll go ahead and move on to the next one. And this question is, what do you mean when you say BPCI Advanced trumps MSSP Track 1, 1+, and 2?
Yeah, great question. So this pertains to how ACOs and BPCI Advanced will interact when an ACO beneficiary presents at a hospital that is participating in BPCI Advanced. And so when I say BPCI Advanced trumps MSSP Track 1, 1+, and 2 ACOs, it means that when that ACO beneficiary presents at the BPCI Advanced hospital and is coded to a DRG that that hospital has selected for BPCI Advanced, the total cost of care for that 90-day period will be then attributed to BPCI instead of the MSSP ACO. On the flip side, if that patient was a next-generation ACO beneficiary or an MSSP Track 3 beneficiary, even though that patient got coded to a DRG that hospital had selected for BPCI Advanced, that patient would get carved out of the BPCI Advanced results, and all the costs from the acute and post-acute portion of that patient's episode of care would still be attributed to the ACO.
Thank you for that clarification, Tom. And this next question is just looking for some suggestions from our participants today, or from our panelists today. And it is, do you have suggestions about how to estimate a completion factor?
Yeah, sure. So, we have been operating this program for the last 5 years, and we've had lots and lots of data, for the episodes of care that we are partnered with health systems to manage in this program. And we've, through our experience, we've been able to develop a pretty good methodology for estimating completion based on claims run out at given points in time. And we have refined this over the last 5 years, where it's fairly accurate today. However, I don't think we have necessarily recommendations that I can make for this type of audience at this stage. Other than to say, I think this is something that as you participate in the BPCI Advanced program, this is something you can refine and look at data to evaluate percent completion of these episodes as the program goes on.
Thank you so much, Tom. And it looks like we have time for at least a few more questions today. So we'll go ahead and try to move through a few more. The next question is, where is the data coming from for the SNF dashboard? Is it just from claims?
Yeah, it's a very good question. So most of the data that we look at in these dashboards are claims-based measures. However, one of NaviHealth's approaches to managing these episodes of care is really to combine some quality data around how patients are recovering in these SNFs and supplement that quality data with what we're seeing in the claims.
Yeah, and I think to add to that, Tom, what we highlighted on the slides are some of the dashboards that are available for providers, including post-acute providers. There are additional tools that we use at NaviHealth. One is NaviHealth Perform, and the other is a severity adjusted dashboard that, to Tom's point, provide additional data and insights into the outcomes that patients are experiencing, particularly in the skilled nursing facility environment. So you see here just a snapshot, but we do complement that with some additional products and analytics that help provide even a deeper level of understanding about that community. And to Tom's point, those are tools that are particularly helpful in driving change and driving adoption among post-acute providers that will partner with acute care hospitals or PGPs.
Thank you both for weighing in there. And the next question that we're going to move on to, it's a multi-part question, but the question is has to do with care redesign. And it said, we are finding not a data challenge, but a regulatory challenge. How are you addressing the regulatory constraints to alignment changes? And if not in BPCI projects, are you able to do so in managed care arrangements?
Sure, that's a helpful question, and it's fair. In some cases, data is not the limiting factor. It may be the program requirements or the regulatory constraints at play. What we've been able to do, and in working very closely with our partners, is really isolating on those key performance indicators and opportunities for improvement, and thinking about ways in which we can make, in some cases, very low-tech changes to our model. So the example I gave earlier about home health at that hospital didn't require any particular extra value add to that patient, but instead it was an adjustment to the workflow and the way in which we discussed the discharge plan that was fully consistent with the implementation protocol that we had in place. I will always, in all of these care redesign efforts, look to that implementation protocol and what will be the care redesign plan in BPCI Advanced as that governing document or that North Star as we think about pilots. There are opportunities, or at least there were in BPCI Model 2, that I would suspect would come into play for BPCI Advanced around the inducement waiver, for example. So there are constraints and rightfully put in place to protect from inducing or the perception of inducing a patient into wanting to participate more actively in this program. We've explored those in the past for other pilot opportunities, and there are processes in place for pilots that may fall into that realm. But you may be surprised at how much innovation is possible within the design of your care redesign plan in the implementation protocol or subsequent documents going forward. And that collaboration with your partners, whether they are within your hospital or external, can be really helpful in thinking about the optimal way to structure that such that you are still within the parameters of the BPCI Advanced program.
Thank you, Gina. And it looks like we have time for maybe one or two more questions. The next question for our panelists today is, will there be an add-drop timeframe similar to the standard program?
Great question. So what we know today is that the first time for participants to add or drop episode groups will be beginning on January 1st, 2020. So essentially, the episode groups that you select to start this October, you'll be locked into those episode group selections for 15 months. Beyond that January 1, 2020 date, we actually don't know the cadence at which there will be episode group add-drop decisions, but expect that CMS will provide more guidance on that going forward.
And it looks like we have time for about one more question today, but as a quick reminder, any of the questions that we aren't able to get to during today's webinar, they will be answered offline by NaviHealth team. So don't worry, all of your questions will be addressed either during the webinar or offline. But I want to go ahead and jump in with our last question for today. And it is, can you elaborate on some real-time low-hanging fruit strategies that can drive change?
Haley, you have come to my heart on this one as a change manager. You know, there are, I think, some good low-hanging strategies here. And I would say, revisiting the last slide in the deck that spoke to identifying those influencers and key decision makers is a really good, easy step to take if it hasn't been done already. Many folks may be somewhat informed, somewhat engaged, but now is really the time to energize that group of key influencers within your organization. There's interesting change management literature that suggests that folks may seem to be on board, but when you scratch a little bit beneath the surface, there may be some hesitation, some questions that they don't feel comfortable raising. So I would say one of the first pieces of low-hanging fruit that I might tackle if I were an organization getting ready for BPCI Advanced would be to rally my team together and begin to talk about any reservations, any concerns, and begin to build that momentum for change so that it can cascade throughout the organization.
Thank you, Gina. And unfortunately, that's all the time that we have for questions today. But I want to thank Gina and Tom for their excellent presentation and to NaviHealth for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.